All right, I think I got the right chapter on tonight, so we'll start there. We'll go over some cardiovascular emergencies. This chapter is pretty intense, so I hope y'all pay attention and make some notes. It goes in pretty in depth. We got a lot of slides to go over tonight, so it may take us a while. I hope not. But anyway, so starting off, going over the pathophysiology of things, we know that. So we talk about medicine. We know what the study of medicine does. Cardiovascular, we talk about anatomy, signs, symptoms, and management of chest pain and cardiac arrest. We'll dive off into that pretty decent, and also show y'all some pretty good slides about how to apply the 3-lead, 4-lead, just give y'all some information on that. That's kind of the latter part of the chapter, but it's pretty good information, so you'll also understand that. We're going to go over tonight of acute coronary syndrome, angina pectoris, myocardial infarction, aortic aneurysm or dissection, which is scary in itself. Talk about thrombolisms, heart failure, hypertensive emergencies. And then cardiovascular disease is the #1 killing of Americans since 1900. About 1 of every 3 deaths are related to some form of cardiac related death. Now that doesn't say that it is a cardiac arrest, but a tamponade or some form of the cardiac tree in itself has caused the death that we're talking about, 1 out of every 3 people. EMS can reduce deaths by encouraging health lifestyles. Why is this? Sorry, y'all. This is like on my screen, and I know y'all can't see it on y'all's end, but so early access to medical care. So if y'all remember when we talk about the chain of survival, y'all should remember that from your CPR classes. We talk about chain of survival, early detection, early notification. That is all in reference to the early access. More CPR training of lay people. I'm all about doing education. There's more reasons to become a CPR instructor than just money, because there's really not a whole lot of money into it, but it's just to train people to help you make your life better when you get out there on these streets. Increased use of involving technology and dispatching cardiac response time. So, and we talk about that because some agencies have, let's say, like the Lucas device. If y'all don't know what Lucas device is, it's the automatic AED. It's the one that you just put on when it does chest compressions for you, and rate and rhythm and all that is preset into the system, and it does it on its own. So some agencies have those in like sprinter trucks, to where the paramedic will sprint to the area and take over and help out. Some agencies have them on every single truck, so it just depends. But the technology that's out there helps. That's like the state of Florida. Florida, technically, any governmental vehicle, state funded, has to have an AED in it. That goes all the way from the garbage to the police to the animal catcher, to everybody. I mean, some of your buses have it. If it receives state funding, they all have to have AEDs on their bus, on those pieces of equipment, which is a really good sense, because it increases the ability to have people there to respond to cardiac arrest. So that's a pretty cool thing that the state of Florida jumped out on a couple of years ago and got ahead of the curve. Now it doesn't want to work when I was pushing a button to make it change. All right, so EMS can help reduce deaths by public access of defibrillation devices. And you know that some malls, shopping centers have them periodically placed throughout. I mean, obviously your hospitals do too, but those are just some public places that you can see those out there, that they're already, the early access is kind of the big thing. And a lot of places now use them for insurance deductions, because it allows them to have these devices out for the public to gain access to. And the use of cardiac specialty centers when they are available. Some of your areas have a cardiac specific facility. Let's say like around me in central Mississippi, we have two places, but mainly one of them is what we call St. Dominic's. They are mainly our cardiac facility. They are not our trauma center, but that's our main cardiac facility. If something goes on, you always want to take your stents and anything that's associated with that cardiac, you want to go to St. Dominic's. Let's talk about anatomy and physiology of the heart. So the biggest thing is for the heart to do is just the heart's job to pump blood supply enriched red blood cells to the tissues of the body. We talked about that last night. We know that how it goes in and how it goes out. But again, the heart is divided down the middle into the left and right side. So each side has a upper chamber, which is your atrium, and that receives blood from the lower ventricle. The lower ventricle to pump outgoing blood. So it's here's a picture. Look at there. So you see your left and right atrium, and then you have your ventricles, and it goes that way. So it comes in and exits, and it has its procedures and its process. And it's one thing that we all have alike. Our hearts function all the same. Some of us may have been born in different rhythms, but hopefully through medicine and medication and then some good cardiologists, they may have got you situated. But that's how it goes, is the four chambers of the muscle. So hint, 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 probably the four chambers and what they are. Gonna be a good test question. All right, so we're gonna talk about more of the anatomy. Is blood leaves each of the four chambers of the heart through one-way valves. So what that is saying is that once that valve closes, you can't push blood back through there. So what I want you to do is we're going to move blood through the circulatory system in the proper direction. So there's no back pressure. If y'all follow me, most of your firemen around here, y'all should understand the one-way valves, and back pressure and making sure it's the same exact type of valve that you have in high-rise facilities that have built-in sprinkler systems, and they're one-way valves. Sorry, I had to break it down to a fireman. So the aorta is the body's main artery. It receives blood ejected from the left ventricle and delivers it all to all other arteries that supply the body's tissues. So as you can see here, the figures on the side illustrate how blood circulates through the heart. On figure A, the right side of the heart receives oxygen, poor blood from the venous circulation. On the left side, the left side of the heart receives oxygen rich from the lungs through the pulmonary vein. So as you can see right down here is oxygen rich blood to the lower part of the body. It's down, pushes out down through the, I'm trying to figure out which one I'm looking at. And then you see, okay, so this goes to the lower part of the body. Notice how it's nice, pretty big. And then these three little valves up here at the top pushes out to the upper part of the head. Then you have your right pulmonary veins, so it goes to your right lung. So it's pretty neat. This breaks it down to the left side because you have to remember you're talking about the opposite side. So even though this picture's on our left-hand side, that is the patient's right, which is always the correct direction. So we always talk about the patient side, not our side. All right, so the heart's electrical system controls heart rate and coordinates the left of the artery and ventricles. So the heart generates its own electrical impulse starting at the sinus node. The impulse passes from the aorta to the ventricles. So the SA nodes is where all of your electricity starts at, and it comes from. The impulse passes from the aorta to the ventricles, automatically allows spontaneous contraction without a simultaneous from a nerve source. So we don't need any type of nerves to tell us what's going on. Basically, the heart functions and has its own impulses by itself. It doesn't rely on the central nervous system to function through it. It has its own electricity. As long as the impulses come from the synovial node, the the other myocardial cells will contract when the impulse reaches them. If no impulses arrive, however, other myocardial cells are capable of creating their own impulses and simultaneously contracting. So basically what it's saying is if there's no contraction and from the SA nodes, it can figure out to say, okay, look, I'm not getting any impulse. Let's turn around and I can make my own. So if there's a electrical impulse failure coming from the SA node, the myocardial cells are like, hey, look, something's going on. We're not receiving pulse. So let's fire. You'll notice right here, this is how the electrical current flows through the heart. It starts right here at the SA node, travels to the AV node, and the bundle of His is right here. This is where it branches off to the parenchymal fibers, and then you have your left bundle branch, comes down into here. So that's the route of electrical. I would probably remember probably all of that if I was you guys. That would probably be a good one to remember, specifically that picture. If you guys have got that. All right, so the ANS controls involuntary activities of the body. It has two parts. It has a sympathetic nervous system and the parasympathetic nervous system. We'll dive off into those and why those do what in just a second. The myocardium must have a continuous supply of oxygen and nutrients to pump blood. Okay, well, we know we all addicted to oxygen. We talked about that earlier, which is important. The cardiac output is increased by increasing the heart rate or the stroke volume. Remember we talked about in a couple of chapters back on how to figure out the stroke volume and all that. So in normal heart rate, the increased oxygen demand of the myocardium itself is accomplished by increasing the amount of blood delivered to the myocardium by dilating the coronary arteries. So what it's going to do is it'll make the blood vessels bigger, and then we're going to turn around and fill it with blood. So if we know that we're going to need more blood, or there's some other reason that they're realizing like, oh man, we need to pump some more blood, instead of constricting, they're going to make their cells bigger and flow more blood through the area. All right. So we're going to talk about coronary arteries are blood vessels that supply blood to the heart muscle. They start at the first part of the aorta, just above the aortic valve. The right coronary artery supplies blood to the right atrium and right ventricle, and in most people, the inferior wall of the left ventricle. The left coronary artery supplies blood to the left atrium and left ventricle, also divides into two major branches in the short distance from the aorta. So let's make that make sense right here. That sounded like a whole lot. So we're going to talk about the coronary arteries right here. There's just the anterior view. So somebody tell me, what is the anterior view? What am I looking at? What's the difference between anterior and posterior?
The front.
The front.
One's the front, one's the back.
Very good.
So what we want to do is we want to make sure that the blood's flowing completely. So like when we do a 12 lead, what we're doing as a paramedic, we're looking at three sides of the heart. We can do some tricky things and with our leads and make them from a 12 to a 15. Basically, all that does is you rotate some leads around to the back side of the patient's body, and you can see a 4D picture of the heart. If you're not used to doing it, some people try to do it and they're like, I don't know what I'm looking at. So it does get confusing too. All right. So the arteries supply oxygenated blood to different parts of the body. So that's why it's so important about breathing is the right and left cricoid arteries supply the head and the brain. That's the reason why if you squeeze somebody's, apply pressure to both sides of the neck, that they pass out, because they lose the blood supply to the brain. The right and left subclavian arteries supply the upper extremities. The brachial artery supplies the arms. The radial and ulnar arteries supply the lower arms and hands. The right and left iliac arteries supply the groin, pelvis, and legs. The right and left femoral arteries supply the legs, and the anterior and posterior tibial and peroneal arteries supply the lower legs and feet. That just sounds like a lot of stuff. I know y'all are probably like, oh my God, I'm already lost. I get it. I know I highly recommend you guys to study pretty well, because this is probably one of the harder chapters that we're going to talk about. So the arterioles and capillaries are smaller veins that receive blood from the arteries. Capillaries are 1 cell thick, exchange nutrients and oxygen for waste at the cellular level. Connect arterioles to venules. The venules and veins receive blood from the capillaries. Venules are the smallest branch of the veins, and a venae cavity returns oxygen-poor blood to the heart. Superior vena cava carries blood from the head and the arms back to the right atrium. Inferior vena cava carries blood from the abdomen, kidneys, and legs to the right atrium. This is important as we tell you guys, and I know y'all are like, what the heck is he talking about? I'm just trying to be an EMT, not a cardiologist. But it is important because you need to understand if there's a loss of blood in a certain area, what particular limbs or area of the body this could be affected. That's why we want y'all to understand that. So blood consists of several types of cells and fluids. So your red blood cells carry oxygen and they remove carbon dioxide. We know that the white blood cells fight infections. Your WC count can be super high, which means you're probably sick. If you have low white blood cell counts and they're low, it means that you're gonna have issues. You need to get those up. Your platelets help clots. So if you have a clotting issue, you could be also low iron, but they can prescribe medication to help with that. Plasma is the fluid that floats in the cells. So the same thing is like if we get a traumatic head injury and we're looking for that cerebral spinal fluid that comes out of the brain that is clear, somebody's like, oh, that's plasma. Well, they have the same consistency, but they're not the same because one's coming from the head and the other one's coming from the blood. But just remember, they do look about the same. And the biggest thing you can tell the difference is the cerebral spinal fluid will create a star if you put out a 4x4. So if you wipe their ear and you lay it beside them and you're taking supplement, if it makes a star, plasma will not. Plasma will just absorb into the white tissue, and you won't be able to tell. That's how you can tell your differences. So blood pressure is the force of circulating blood against arterial walls. Systolic blood pressure is the maximum pressure generated in the arm and legs during the contraction of the left ventricle during the time period known as systole. Diastolic blood pressure is the pressure against artery walls while the left ventricle relaxes. Somebody tell me, on a systolic or diastolic blood pressure, which one is your top number, which one is your bottom number?
Systolic over diastolic.
Correct. Good job. Good job. Got to make sure at least somebody's here. So a pulse is felt when blood passes through the artery during systole. Peripheral pulses are felt in the extremities. You have your radial pulse and your posterior tibial pulse, and central pulses are felt near the trunk of the body, and that's i.e. your femoral artery or your cricoid artery. So here is your cricoid is at your neck. You have your brachial. You have your posterior tibial. You should feel that on the inside of the ankle. You have your femoral, and I'm gonna tell you for your femoral, I tell you a good thing. And if y'all have children, and I don't want y'all to torment your children as you go through this class, but it is a lot easier to feel these pulses on your children, specifically your femoral, and then move up a better half, a husband, wife, it doesn't really matter. But then once you find them on the smaller children, move your way up so you can feel them on the adults. Now, if you don't, you can feel them on yourself, specifically all of them, but the femoral one is very complicated to feel. So that being said, is know that it's not, it is a good sign if there's a trauma, if you reach up to feel a femoral pulse, but also in the back of your mind, understand that when the body is in a traumatic situation, everything from down here is going to start shunting to the core of the body. So your radial pulse may disappear, your tibial, your diastalis pedis are probably going to disappear. So you may really only feel your femoral, cricoid, and your brachial. I have had patients that had no radial pulses. And we ended up, I was able to increase the fluids and all that and got a radial pulse back, but they did have a massive blood loss. So just know when you start losing pressures that you're going to turn around and start losing blood pressures in certain, or pulses in certain areas. Whew. All right, so cardiac output is defined as the volume of blood that passes through the heart in 1 minute. So calculated by multiplying the heart rate by the volume of blood ejected with each contraction is the stroke volume. In the field, stroke volume can be roughly determined by the heart rate and the strength of a patient's pulse. Perfusion describes the constant flow of oxygenated blood to the tissues. Good perfusion requires the following: a well-functioning heart, an adequate volume of fluid or blood. Blood vessels must be appropriately constricted to match the volume of blood available. And if perfusion fails, cellular death occurs and eventually the patient will die. So that being said, is if you know that you are losing blood and the patient is losing it pretty rapidly, you want to try to stop that so you don't end up, obviously we're gonna die if we don't fix it, but we need to stop it and help it coagulate or at least slow it down. Give me 2 seconds, y'all. All right, sorry about that. All right, so is everybody with me? I feel like I am just
here.
like y'all. I know
Right
it
here,
is a
brother.
lot.
Trying to follow.
I'm here.
So it's one of those like this is probably, to me, this is the hardest chapter that we come through because it is so much, and it's like there's so much that they can pull tests from. So I don't even know how to make this fun, y'all. I'm sorry, but it is a lot better than the medical terminology class. I promise you. My wife's over there shaking her head like, yeah, because I badgered that. So chest pain. So a heart-related chest pain usually stems from ischemia, which is decreased blood flow to the heart of inefficient supply of blood and nutrients. So ischemia heart disease involves decrease in blood flow to one or more portions of the heart muscle. So if the blood flow is not restored, the tissue dies. So you can't get that tissue back. So let's say if you have a 10% chance, you lose 10% of your functionality if you go into cardiac arrest for every minute that you're down. So now that's not counting cold water. So I'm not talking about a cold water drowning or anything like that. I'm only specifically saying if you coded sitting right there at your living room table or your living room couch, you coded. So for as long as you're down, you start losing those cardiac muscles and you don't get them back. So if you revive somebody and they've been down for 5 to 10 minutes, that's very lucky that you get them back and they've been down for longer than 10 minutes. But just know that they lose they're losing parts of their tissue. Their heart it's dying. They may put them on a transfer list at that point because they're realizing that their heart muscles are dying. Right. Arthroscorosis is a disorder which the calcium and the cholesterol build up from a plaque inside the wall vessels. It can cause complete occlusion or blockage of the coronary artery and other arteries of the body. So that's where they also go in here and they basically rotor and they clean your pipes out. See right in here, and this is all the plaque. So what they do is they'll come through here and they'll clean your pipes out and they'll get rid of all this and make it look like this again. Fatty material accumulates as a person ages, resulting in the narrowing of the lumen. The inner wall of the artery becomes rough and brittle. If brittle plaque develops a crack for any Lord knows what reason, the ragged edge of the crack activates the blood clotting system, resulting in blood clots that will partially complete the blockage of the lumen of the artery. So right in here, if it realizes that this is cracked right in here, the body's automatic response is to start putting a clotting material here. And now this circle that's down here is going to get even smaller because the body's doing what it's supposed to do and going to automatically clot it. So we're helping ourselves, but we're hurting ourselves because of that. Let me move something real quick. All right. So thrombolism is a blood clot that floats through the blood vessels. If it reaches an area that's too narrow for it to pass, it stops and blocks blood flow of that point. So tissues downstream from the blood clot will suffer from hypoxia. They just don't get no more oxygen. They're going down. If too much time passes before blood flow is resumed, the tissues will die too. The sequence of events is known as acute myocardial infarction, which is an AMI, as a classic heart attack. So the death of a heart muscle can severely diminish the heart's ability to pump. So if you know that you're going to a myocardial infarction, most of your dispatchers will be like responding to a heart attack. So they're not going to sit there and be like, it's an acute, because even though they MD the call, they don't get down to that deep. They're automatically going to categorize it as a possible heart attack. So, all right. So in the United States, coronary artery disease is the #1 cause of death for men and women. So the peak incidence of heart disease is between 45 and 64 years of age, but it can strike in individuals ranging from their teens to their 90s. Risk factor place a person at high risk for an AMI. A major controllable risk factors are cigarette smoking, high blood pressure, elevated cholesterol levels, diabetes, lack of exercise, and obesity. Some of the uncontrollable risk factors are older age. So they're telling us that we can lower our chances if we stop doing all this and we start working out, but we can't just because we get old, we can't help that. If you have family history of a MI, it increases your chance even more. If you have coronary artery disease, I'm not sure when they refer to race about what they're referring to. I don't know one race that has them higher than others. I will tell you a trick though I've learned. Most African American females, do not and will not show signs of a heart attack. They just don't do it. I went to a lady one time. She's like, I don't know, I just don't feel good. She was telling me everything. She was literally cooking, and the family called. And I said, well, ma'am, if you don't mind, let me just check your blood pressure real quick. Anyway, I ended up getting a monitor on her and put her on just a 4-lead and recognized that she was having a heart attack right then and there. So they just didn't show the signs and symptoms. Caesar says African Americans have the highest rate. So there we go right there. But I'm gonna tell you, the females for African Americans will not show signs and symptoms. So you have to make sure that you're on your game and be prepared for those. Why does it not work? So an ACS is acute coronary syndrome, describes a group of symptoms caused by myocardial ischemia. So this includes temporary myocardial ischemia, resulting in angina pectoris, or a more serious condition of an AMI. I think let me see. I think we go further into what is what here. All right, here we go. So angina occurs when the heart's need for oxygen exceeds the ability to supply, usually during physical or emotional stress. So a lot of people during sporting events, hiking events, or serious emotional distress will have angina. What that is it mimics a heart attack. It mimics all the signs and symptoms. So it may not have anything on their heart, but it does mimic those. And this may be triggered by a large meal or sudden fear. When increased oxygen demand goes away, the pain typically goes away also. Angina pain is commonly described as crushing, squeezing, or somebody is standing on my chest. Usually felt in the mid portion of the chest under the sternum. And it can radiate to the jaw, arms, but it's frequently the left arm, mid back, or the epigastrium area. It usually is going to take anywhere between 3 to 8 minutes, but not really much longer than that. The reason why we say that is most of the time people recognize it and say, "Oh Lord, what is this?" They sit down, they start taking a break, they get their breath, they're able to breathe and get things situated, and that's why the 3 to 8 minutes kind of alleviates that angina. Unstable angina is characterized by pain or discomfort that is in the absence of significant increase of myocardial oxygen demand. So now you understand why we say put people on oxygen. No matter what, always put them on oxygen. Stable angina is characterized by pain in the chest of the coronary organ that occurs in response to the exercise or some activity that increases the demand of the heart muscle that is beyond the heart's capacity to increase its own blood flow. So you have a lot of people in their elderly, hell, I'm gonna even say my age, that start exercising and they exercise heavy. Well, the oxygen demand decreases. Will they start having this angina? They start having this, oh my God, I think I'm having a heart attack. So you start working out of the no blue, and or you go hiking and you start hiking at heights and you start having these chest pains, and it could be from angina. So patients experience chest pain or discomfort should always be treated as they are potentially having a heart attack. So what we want to do, you good, son? Oh my Lord, my son is he's the smartest dumb kid I know. So if you think that they're having angina, even though you put them on the monitor, depending on where you're at, if your agency allows you to, and you recognize, you're like, well, you know, everything appears to be fine, there's a stable or unstable angina. You need to clarify which one is which, and then you still want to treat and follow your procedural protocols on how that's written, and go from there. That one. All right. So the pain of an AMI sign signals the acute death of cells that are area of the heart where blood flow is obstructed. So it's going to start killing them. So once they're dead, the cells cannot be revived. You can't fly an AED and fix them and put them back to health. They will turn to scar tissue and become a burden to the beating heart. And about 30 minutes after blood flow is cut off, some heart muscles begin to die. After about 2 hours, as many as half of the cells in the area may be dead. After 4 to 6 hours, there are more than 90% of the cells will die. Opening the coronary artery with either clot busting, a thrombolytic drug, or a angioplasty can prevent permanent damage if this is done within the first few hours. So what we say is that is called the golden hour. So if you know that you get somebody and you start to recognize that they're having a stroke, everybody hears about the golden hour of the stroke. It's the same thing when you start to recognize chest pain, you need to get them to the most appropriate facility as fast as you can, because that's just as important is having them to a stroke facility in a timely manner. And the reason why is you need to get them so they can have this medicine in place and on hand. Can y'all see that? I just rolled that over there to y'all. Was that in y'all's screen? I'm sorry, I was changing topics for a second. I'm trying to realign some stuff on my screen.
I didn't see anything. I just saw your mouse go from one side to the other.
Yeah, if y'all notice, I play and it keeps and when I put it over here, it comes in, then I move it back. So I'm running my computer off of my Mac and my iPad, so I have dual screens. And for me to make sure that it doesn't go to sleep or anything, I constantly play with the mouse. That's why y'all see it. I'm sorry. All right, so we need to treat them in the golden hour. So it's the same thing as a trauma, as anything else that we want to, most appropriate facility as fast as we can get it there, and the most appropriate time, and the safest way possible. All right, so here's some signs and symptoms. Signs and symptoms will be sudden onset of weakness, nausea or sweating, chest pain, discomfort of pressure that is often crushing or squeezing that does not change with each breath, pain, discomfort, or pressure in the lower jaw, arms, back, abdomen, or neck. Most of the time you'll notice that it's going to be, they'll complain of, like jaw pain or like, man, my arm is just numb. Irregular heartbeat or syncope, shortness of breath, nausea and vomiting, a pink frothy sputum. I'm gonna tell you, I ain't ever noticed that, because that makes me think they sick. And if they have that, I'm definitely not thinking an AMI. I can promise you. I'm thinking they probably have TB, or they just die like in front of your face. Like I walked up in a gas station. They said, Mr. White's not looking so good, and I was like, oh, okay, what's up, Mr. White? Boom, he died like right then. He looked at me, and I think I scared him. I was the ugliest thing he's seen. He just died right there. So it happens. The pain of an AMI differs from the pain of angina in 3 ways. So this is important. It may or may not be caused by exertion and can occur at any time. Sometimes when a person is sitting quietly or even sleeping, it can wake them up. It does not resolve in a few minutes. Rather, it can last between 30 minutes and several hours. It may or may not be relieved by rest or nitroglycerin. Note all patients who are having an AMI experience pain or recognize when it occurs. When called to a scene where the chief complaint is chest pain, always do a thorough assessment no matter what the patient says. And I don't know if I've told y'all about nitroglycerin. I'm sure I have. But anytime that you provide nitroglycerin and they complain of a quick, rapid onset of a headache, well, you can take the chest pain stuff away because they're probably not having any cardiac pains. There's a nitro. If it doesn't fix the cardiac problem, it automatically triggers a migraine or headache. Physical findings of an AMI and cardiac compromise. General appearance, they are fear, they have nausea, they have poor circulation. Their pulse is faster, irregular, or bradycardic. Their blood pressure is decreased. Could be normal or elevated. One, if they just say that the blood pressure may not be normal, that would be the easiest. Respirations could be normal, rapid, or labored. And the mental status, the feelings of impending doom. So I'll go ahead and tell you, because we're going to see this again. When somebody looks at you and says, I'm going to die, don't blow them off. Don't just be like, oh, okay, whatever. They know it. It is a feeling that they get. It is so just best thing I can tell you is if they tell you, be like, I think I'm fixing to die, just believe them. I'm just gonna tell you it's for the benefit of you, and go ahead and get your stuff ready because you're finna be working code. An AMI can have 3 serious consequences: sudden death, cardiogenic shock, and congestive heart failure. This rhythmia ascribes to an abnormality of the heart rhythm. So if you have a normal heart rate, that is, everything is fine, but if you show dysrhythmias, you're gonna have a premature ventricle contractions that are extra beats in the damaged ventricle. I wish I had some rhythms I could show you guys, but y'all wouldn't understand them. I don't think harmless. They are harmless and common among healthy as well as sick people. I've seen people throw. So there's different ones. You have PVCs, PJCs, pre-ventricle contraction, and they, you can see them sometimes. I mean, hell, normal healthy people may throw a PAC or a PJC, so it just depends. So tachycardia describes beating of the heart at 100 beats a minute or more. So your normal sinus rhythm is about 60 to 100. Anything that goes over tachycardia, anything goes over 100 is a tachycardia rhythm. So then you have bradycardia, describes unusually slow beats of the heart at 60 beats or less. Ventricle tachycardia describes to a very rapid heartbeat of 150 to 200. This is the fun one to get because you can give them a medication that stops their heart and they just look at you and go, oh. And you pray everything that starts back like normal because that's kind of what you want. Is when you give this medication, you're like, okay, start. Okay, whew, there it goes. So when you give it to them, you actually see their heart rate, just their pulse just stop because the heart stops, and you're praying that reset button works. So if you get the ventricle tachycardia, this may deteriorate into a ventricle fibrillation. So you may have VFib, and that describes as disorganized, ineffective quivering of the ventricles. So I highly suggest you guys look these up on YouTube so you can see how the heart beats in these rhythms. I should have been a really good instructor and got the links and add them into your page. So Tamara, you have a PVC. So do you have multifocal or do you have regular PVCs? I'm gonna put you on the spot for a minute. My mom has this.
That's all they
So
said. It was regular PVC.
Okay.
I don't
So your
take
mama
nothing for it.
stays in
They just
SVT?
watch it. Pardon?
So your mama stays in SVT?
She has to take medication on a daily basis for it to keep it in check. But even with her meds, sometimes if somebody's like driving past the house and their base is way up or something, then it'll throw her into tachycardia.
So you know the words you're saying, you don't scare mom.
Yes.
Well, there goes how. No, I'm just kidding. So yeah, and Tamara, and it's not unusual to have PVCs. It could just be an electrical firing issue, but it's not like an issue. It's just an extra electrical fire. I'm sure. I'm not picking on anybody. I don't know your age. I don't even know what you look like, but I'm sure the older that you get, and I like to say the wiser because I don't like the word old. I'm 41 now, so it sucks. But the wiser that you get, they may turn around and start watching that. It could go into like an AFib rhythm. So it's not like it's bad by no means, and I'm sure that's what your doctors told you. They say they just watch it. Now SVT that can be serious, but I hope that nobody scares her and triggers that. See, Miss Tamara, I knew we right there at the same age. See, we got this.
My mom, she didn't realize she had the issue until she hit like mid-30s.
Mm-hmm.
And
Well,
she's in her late 40s now.
Damn, don't say that. Made me feel like I'm old enough to be your daddy. Woo.
I get that a lot.
Keep
It's
going.
okay.
I never knew I had anything
All right.
wrong with me until I was in West Virginia doing travel CNA, and I got dizzy and lightheaded, and they made me go to the emergency room, and that's what it was.
You thought your sugar was a little low, but now it's your heart telling you to sit down. So
Yeah, I used to work 14 and 16-hour shifts, like 5 days a week. So yeah, I needed to slow down a little bit.
Bet you don't do that no more, do you?
No, because they won't let me.
All right. Well, I'm glad to hear that you're doing okay with the PVCs and your mom's doing fine, Rebecca. I'm glad to hear that. What?
I don't know. Chewing on the chip, and I heard one too.
Stand by 1 second, guys. All right, so talking about defibrillation, defib. So when we talk about defib, basically what we're doing is we're introducing high voltage shocks to a patient. Has anybody in here ever had the unfortunate ability to give somebody a shock? Or has anybody received one? Let's put it that way too.
I worked a few codes where we had to.
Okay, so it is not a pleasant. It's not pleasant. The first time you see it, you're like, "Wow, that's cool," but then you're like, "Oh, that kind of sucks because Fred ain't coming back." Most of the time, I'll say, and I don't want to say that I have bad luck, but I really have terrible luck. But I've only had, out of my 20 years, I've only had like one or two I've ever brought back out of all the cardiac arrest I've worked. So I'm a lot better at delivering babies. I delivered like 9 or 10, and that was early on in my career. Those are a lot easier to do. So defib, it can save lives, obviously, if the shocks are delivered within the first few minutes of sudden death. And that's the reason why we, in CPR, if y'all remember, we do 1 round of CPR and chest compressions on infants, and then we go get the AED on adults. We go get the AED first and come back. And just think about it, it's because of the muscles in the body. Children's will decompensate a lot faster than adults will. That's why we do that. But CPR must be initiated when the defib is available. You can't just save somebody with CPR. You have to have a defib. That is your best chance of survival, is to do with both. Chances of survival diminish approximately 7 to 10% for each minute until defib is accomplished. It's like I knew what was coming up. I already told y'all that. Asystole is the absence of heart electrical activity. It usually affects as long periods of ischemia. Nearly all patients with asystole will die. So, everybody, does anybody know what asystole is?
I don't know what that is.
Okay.
Didn't they
Can't
just do a
remember.
flatline rhythm?
Joseph, I didn't hear you. I know you said something first.
Isn't it your flatline rhythm?
Correct. Miss Rebecca, I heard you.
Yes, it's been a few years since I did my EKG seminar. So yeah, I couldn't remember.
I love cardiology. I love to sit through it and interpret rhythms. Even though there's only so many, there's so many out there. But yes, so if you hear somebody saying, "Hey, he's flatline," and you look at it like in a movie and there's actually beats on the thing, that drives me insane. But asystole is flatline. You have no cardiac electrical beats, no nothing at all. Out there at all. You can go into a PEA rhythm. It's premature electrical activity. So that also is non-life sustaining. So you cannot shock a systole. There's the AED is automatically set. It knows what it can and can't shock. So if you apply just the AED and you turn to try to shock it, it will not allow you to shock it in asystole or PEA. You have to have a certain type of rhythm for it to work. Now, as you move further on in your career, whatever way you decide, if you turn around and go through advanced or through paramedic, you will be able to study these, and you have to know them. Our really good instructor that teaches our advanced class, he goes over these pretty well. And the reason why is some states allow EMTs to do that. Unfortunately, right now, currently, my state does not, in Mississippi. That is actually being worked on by our lieutenant governor as we speak. But you can learn some of these different these rhythms and all that. So why does my computer do this sometimes? No, it's not. So shock occurs when the body tissue does not get enough oxygen. It's causing the body organs to malfunction. Cardiogenic shock is often caused by a heart attack. The heart lacks the power to force enough blood through the circulatory system. It is more common in the AMI, affecting the inferior and posterior regions of the left ventricle. It is important to recognize shock in its early stages. Now, it is harder to recognize cardiovascular shock than it is to see it like if you're going into shock because of blood loss. It is just super hard to see it, and you will notice it after the fact, and that's what sucks, because you're like, oh crap, they were going to cardiogenic shock. So that's the easy way. I've seen it, didn't realize what it was until it was after the fact. And I mean, the patient was pretty much circling a drain. I was doing everything I could to save this person, but you know, we're not gods. We are taught with some knowledge to make ourselves better, but it is what it is. Congestive heart failure often occurs when the first few days after a myocardial infarction. A CHF develops when the increased heart rate and enlargement of the left ventricle no longer make up for decreased heart. It is called congestive because the lungs become congested with fluid. That is where you get your pulmonary edema. And once the heart fails to pump effectively, it occurs suddenly or slowly over a few months. An acute onset of CHF, you have severe pulmonary edema, is accompanied by the pink frothy sputum and severe dyspnea. With right-sided heart failure, blood backs up in the vena cava, causing fluid to collect in other parts of the body. And that's dependent edema because it has nowhere to push it. If there's pleural space in your right arm, guess where that fluid's going? It's going to go to your right arm. And you're like, geez, do I have elephantitis with the right arm? No, you're having cardiac issues, and it's shunting to the pleural space. Right heart failure can result in an inadequate supply of blood to the left ventricle, resulting in a drop of the systemic blood pressure. Patients may present with signs of both left and right side heart failure because the left side failure often leads to the right side failure because they pump back and forth with each other. So it's a tag team. Well, when one fails, the other one tries its best to pick up, but it just can't do it. It can't take the workload of both of them. Like your kidneys, you can live with one and you can live with one lung, but you got to have both muscles of the heart to function. Hypertensive emergencies. Oh, hang on, let's see. We'll take a break. Hopefully by the time we get through these 22 right here. So hypertensive emergencies, they involve any systolic blood pressure greater than 180 millimeters of mercury. So the mmHg is millimeters of mercury. I don't know if y'all knew that. Or a rapid increase in the systolic pressure. Sudden severe headache is common, and some other symptoms are strong bounding pulse and ringing of the ears. I will give y'all, how do I put this? For the first person that types it in the chat, what is ringing of the ears called? I will give you 5 points on your next test. Oh, y'all some Googling fools, I can tell. Joseph, tendonitis. Somebody else? Somebody want to argue with it? Y'all good there? What you think? You think he's right?
I process disability claims for veterans for a living.
I barely heard you, I'm sorry.
I
Google's not
process
loading.
disability claims for vets for a living.
Hey, well then you are 100% on that. I can tell you, even with the crappy headphones I was given in Afghanistan, I still have trouble. I can't hear nothing out of my left ear, but that's a whole nother story. All right, so let me write that down, that you get 5 points. All right. See, he already knew that one and he was ready to go. All right. So we should get 2 if we agree. Saying you get 2 extra points. All right. So some of your things with hypertensive, and y'all know hypertensive means high because of hyper. So that's high blood pressure. So some of the things you're going to get is nausea and vomiting, dizziness. You get dry or more moist skin. You get nosebleeds, altered mental status, sudden development of pulmonary edema. The last 2 are your most severe. I will say that's kind of leading to the worst case scenario. So when that takes place, know that that patient is probably when you go to check their blood pressure, it's going to be extremely high. Like it's going to be, when you go to check it, you'd be like, no, this has got to be wrong. There ain't no way they like 200. Yeah, they really are. So it's high. Just know that the nosebleeds can happen periodically, very easy, because the blood vessels in the nose are pretty close to the surface, so it's easy for them to burst when the pressure gets too high. So I would kind of say the E, or the last 3 on your screen, show leading up to the worst. Untreated hypertensive emergencies can lead to a stroke or dissecting aortic aneurysm, which is horrible. Transporting patients to the hospital as quickly as safely as possible. Consider ALS assistance depending on transport distance and time. And to be honest, the best thing we can do is we can give them fluid. We don't want to overload them with fluid because we know that their fluid levels are already high because of their blood pressure. But there's a few things that we can do on the side to try to help with that. 2 more and we'll take a break, y'all. So the aortic aneurysm describes a weakness in the wall of the aorta. This is fatal. I'm gonna tell you right now, if you're not on the table when this ruptures, it's fatal. The aorta dilates at the weakened area, which makes it susceptible to a rupture. If it ruptures, the blood loss will cause the patient to die almost immediately. Uncontrolled hypertension in the pulmonary cause is the primary cause of this dissecting aortic aneurysm. A dissecting aneurysm occurs when the inner layers of the aorta become separated, allowing blood to flow at high pressures between the layers. So the way that I think of this, everybody think about the bubble on the outside of a tire, like right there at your rim. So that bubble, what that is because it's a weakened spot in that tire, and you see this bubble and you're like, oh my God, that doesn't look good. Oh God, I hope it holds off because I don't have the money for that tire right now. So you keep driving it. Well, the bubble gets bigger. So your blood pressure is getting more intense and it's not being treated. Now, if you'd have gone to the tire shop, maybe you could have found, a cheaper tire, I don't want to say a patch job because you can't patch that, but they could have patched you on until you found a better time to buy a new tire. maybe a used spare tire or something. But you keep rolling. Well, all of a sudden, that pressure, you're going down the highway and you're going so fast, the air, it spans, well, it blows out. Well, you're going to wreck, most likely, because you're going at high speed, and you're going to lose a tire because it has blown, it's blown that valve and it ruptures. So all the air is going straight out the side. It's kind of the same way that takes place. I hope y'all got that. That's honestly the way that I learned it in school, and I still sticks with me. So continuing with the signs and symptoms include very sudden chest pains located at the anterior part of the chest and in the back between the shoulder blades. It's going to be very difficult to differentiate the pain of a dissecting aortic aneurysm of an versus an MI. Transport patients to hospital. So, and I'll tell you this too. If you have somebody with a dissecting aortic aneurysm, do not be rough with them. They're going to die. There's nothing you can do about it. But the rougher you are, the faster they're going to die. So I can promise you it's a lot less paperwork if you're just slow, methodical, and you get them there as fast as you can, but you're smooth about it. I promise you. All right, so looking right here is AMI versus dissecting aortic aneurysm. I'm gonna leave that on the screen. I'm gonna let y'all take a few minutes and look at that. I show it to be 1 after 7. We're gonna take a 10-minute break. I'm gonna leave that on the screen for y'all to look at, and then or 2 after. So I will see y'all at 12 after 7. Be back in a few minutes, and we'll go over some questions that you all may have. See y'all in just a few minutes. All right, folks, so what questions do we have to this point?
What is it called whenever the two numbers of the blood pressure get closer together?
Emma, I'm having trouble hearing you. I don't know if it's on my end, but do you mind trying to type that in the chat real quick? All right, so you say, what is it called when the two numbers of the blood pressure get close together? So that's called a narrowing pressure. So you'll get that to I'm trying to read a text message at the same time, so that's why I'm stuttering here. So narrowing pressure, so if, let's see, let's give you an example. So if your systolic blood pressure is around, let's say 110, and your diastolic is around, let's say around 80 to 90, those are narrowing pulse pressures. So what that's going to do is give you an idea that you're close to having heart failure. Is that what you were looking for? All right, good deal. All right, so moving right along. Let's see. I don't got that many more. We're about halfway done. All right, so our scene size up, scene safety. Every bit that we do, I want you all to refer back to your National Registry test, your assessment skills, and that is going to be the same. Is it BSI scene safe? I look for the scene, I look for the drive-in, I look for the radio traffic, all to give me information about the scene safety. And sometimes they may say it's safe and it's not. And once you get there, you're like, oh God, I got to drive right past it. And that's okay. Just don't stand close, just don't stage close enough where they can see you. That ends up being a bad idea in the long run. So let's see, we know about the NOI. Former general impression, y'all. I'm actually gonna skip some of this here because we should know this. I do want to talk about this one right here. Formal general impression. Obviously, if they're not breathing, begin CPR and call for an AED. By God, I hope if you're on the ambulance and you're pulling in with this equipment already, that's just what I'm hoping. So on the oxygen, so if you have a pulse ox and you put it on and it's 95 or less, they want you to go ahead and put 4 liters of oxygen on. Now, you may have that in your test station, where it's a tool when you're doing your physical exam, put it on. And it never hurts whatsoever to apply somebody on oxygen, but they may ask, at what reading would you automatically put somebody on O2? So there you go, 95 or less. So if they're not breathing or they have inadequate breathing, 100% oxygen with the bag mask device. So you're looking for a BVM, you're looking for an ambu bag. They're the same exact things, but that's what they're called. So assess breathing to determine whether the ailing heart is receiving adequate oxygen. If they do not improve quickly, apply oxygen. We've talked about that. Give them, give them, give them. It's cheap and easy. We know about the circularization. We talked about that, check for pulses. We went over that pretty in depth the other day. Transport decisions, am I going to stay in play or am I going to hurry up and go? Am I going to try to get an ALS to meet me on the way in so they can take this patient from me? History taken, we went in depth over this. I don't feel that we need to continue to harp on that. I believe it is. We do need to harp on that when we talk about your skills. When we know that you have to dig in and ask these questions. If the patient is not responsive, we ask the bystanders or family around. But at the same time, as if you have somebody that is trying to answer all the questions, again, be respectful, but at the same time, we want the patient to speak. So we would say, thank you so much. I appreciate the information, but I'm trying to get Mr. Fred to tell me in his words, what is he feeling? And everybody's like, oh, I already told you that. He's going to take 20 minutes to answer it. I get paid by the hour, not by the call. You know, that's that's always my favorite go-to. People don't really like that, but oh well. So history taken. Here's some other questions that you can talk about. When you go about quality, it shows you right here. Ask the patient to describe his or her pain. Let the patient use his or own words to describe what is happening. If the patient is unable to describe the pain, try to avoid. Supply only one question. Do not ask, does it feel like an elephant is sitting on your chest? Instead, say, tell me what the pain feels like. So you want to ask open-ended questions and some that are yes or no. Did this start today or tomorrow? Well, no. Well, no what? No, it didn't start today. Okay, when did it start? So you can ask simple questions like that. Obviously, if they're having trouble speaking, let's ask those questions a little bit. We'll put them on some oxygen and go from there. We talked about the physical exam. We'll do our focused and our rapid. We still, no matter what, want to do a rapid exam just to make sure that there's something else not causing the issues or the pain. We do want to know what their vital signs are, and vital signs include pulse, temperature, vitals, respirations. And I mean, now a lot of places want to know the temperature, but I'm not a temperature kind of guy. I don't really like to ask that because that's so opened because I mean, hell, it's 1,000 degrees outside in Mississippi right now. So they may be 100 degrees where everybody thinks that they're having fever. Well, they're not. It's just what it is. So, and again, measure all your vital signs, get a baseline, and then you want to do that every 5 to 10 minutes. Turn lights up. And there. So your reassessment, again, here, you'll notice how it says reassess every 5 minutes. If the patient's condition changes, if it is a non-critical patient, you can do it every 10 minutes. Most of your most of your monitors, I don't know what kind you have, but I can tell you your Zoll, your Life Packs, and your Philips can be preset to do it every 10 minutes. So that's not something that you have to continuously think about. It automatically gets it. Reassess, make sure your interventions are working. If you did something, consistently recheck it and to monitor to see what it is. And you want to continuously to provide rapid transport depending on what's going on and the status of the patient. So your emergency medical care for chest pains. Okay. So allow the patient to sit up to most comfortable. We talked about that. Most of them want to sit at a 45 degree. That's fine. I don't really care if you lay flat. Doesn't bother me. And loosen, tight fitting clothes. Well, good thing about being fat, I don't have to worry about that. No, I'm just kidding. So you always give oxygen in, and I don't like where it says if indicated because they're having chest pains. It's required by your protocols. Continuously assess oxygen saturation on the patient, which means I want to look at their O2 stats. Use nasal cannula if the patient for mild dyspnea. Use a non-rebreather or a face mask with patients with more severe. If signs of pulmonary edema are present, you could use a CPAP, but that again, let's fall back to what your protocols say that you can do. If they don't allow you to use CPAP, you know that you need it, so you're going to have to get an advanced or a paramedic to show up to be able to do that. And if they are unconscious, you start breathing in CPR as fast as you can. Depending on your local protocols, be prepared to administer a low dose of aspirin and assist with prescribed nitroglycerin. If they don't have the nitro, you cannot give it. So you have to make sure that they have it. If they have it, here's your question. I notice you have nitro. Have you had a heart attack before? Yes. Okay. Does this feel just like it was the last time, or is there any different? Is there any different from what you feel before versus what you feel now? If they say yes or no, then that gives you an idea of what you can and can't give. All right, so aspirin, we want to give 324 milligrams out of the 81 milligram chewable tablets. So sorry, I got thirsty. I thought you just took that test, Reginald. How'd you get in there? I know you said this was a test question. Didn't you take that already? I get an email every single time that y'all take a test, I promise you. Yeah, I thought so. Trust me, anytime, day, night, it doesn't matter. Rob and I get emails about who takes tests when. I don't even know. I get tests from the advanced class, from the in-person basics. I get them all. There's sometimes I'm like, I don't even know this name. Why is it emailing me? The benefits of being a coordinator. So on the aspirin, it is 81 milligram chewable tablets, but you have to give them 4 of the 324 milligrams. So, and make sure they chew them. They have to chew it. You can't just swallow it. Nitroglycerin. So if they have it on them, a majority of the time it's going to be in a little dark tainted bottle because it has to be protected from sunlight. You want to make sure you unscrew it in a well ventilated area. Drop 1 pill into the cap and then ask the patient to push their tongue to the top of their mouth and put it underneath their tongue. It has to be their medication, so you as a basic can help deliver that. If they have sublingual spray, which is very rare, that may just be the same thing that you spray underneath your mouth, but it is going to be rare that these patients have these. And if they have a skin patch, so they have a transdermal patch, they could be prescribed these. If they do, you can put them on as well. But note what time you put it on so you can move forward and go and reassess it as you go throughout. It does help with the pain. It can reduce the pain for the nitro. But again, I say this, if they say, oh my God, I'm having a massive headache, I'm okay with that because I know it's not cardiac related then. But then if they say, well, yeah, my pain's going down, you're like, oh shit, they're having a heart attack. Oh God, let's go faster. So that's the 2 benefits about nitro, how it does help you. So nitroglycerin, it does relax the muscles of the blood vessels, dilates the coronary arteries, so it allows more blood to flow. It increases the blood flow and supply to the heart, and it decreases the workload of the heart because of the dilation. Once it gets dilated, it doesn't have to work as hard to get the blood to the heart. So that's why that it helps decrease the workload. Here are side effects. Decreased blood pressure. I always have once you get on up into your advanced or paramedic, never, ever give a medication without an IV established. Period. I don't care if it's nitro spray. I don't care if it's sublingual. Never give a medication besides Narcan. Let's get that out there. Narcan, you don't need that. But you always want an IV established before any medication. So it does decrease the blood pressure. So I can fix that if I already have an IV established. But if they get the severe headache, ding, 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 we know that that's not cardiac related. So here's your contraindications of this medication. So of the contraindications, your systolic blood pressure is less than 100. If they have a presence of a head injury, if they've used a erectile dysfunction drug within the last 24 to 48 hours, and they have had the maximum prescribed dose has already been given. If they've taken 3 prior to your arrival, you cannot give any more. This is important that you know the contraindications. The contraindications are very important, so you know what not to give it for. All right, so cardiac monitoring. So for ECG, which is electronic cardiogram, to be reliable and useful, the electrodes must be placed in consistent positions on each patient. Certain basic principles should be followed to achieve the best skin contact and minimize arterial artifact in the signal. Now, how many of you have Apple Watches? All right. Reginald, have you seen lately, since you don't want to answer, I'll pick on you. Have you seen that you can technically do a 12 lead on yourself with an Apple Watch in multiple different positions? And it is a 97% accuracy. That's pretty jam up for a watch, just gonna say. So on your ECG leads, at the same time, my son should, at the same time, what you need to do is, I love mine. I checked my heart rate today because I thought the heat was gonna kill me. So you need to make sure that your ECG leads are in date and that they're not, they do get a little rough when you expose them to heat because they are sticky. They have the gel in there. And once that gel is applied to them, they get a little, they kind of lose their ability. It's best to make sure that you have, most of the time, if you're on a pretty active ambulance, you're going to be using them prior to their date. But that's also important, is make sure. And make sure it doesn't slip, or I will tell you. It may occasionally be necessary to shave body hair from the electrode site. It's the same thing that you want to do at the same point with a AED. If you're going to put an AED pad and they're super hairy, most of your services should carry a small disposable throwaway razor, and it's different than the Bic razor. Some places use Bic razors. I don't like using Bic razors on regular ECGs just because it's not, people don't like you when you do it that way. On a heart attack, it's okay because you ain't got to see them once it's over with. You just leave. But rub the electrode site briskly with an alcohol swab before application of the skin, because what it does is helps remove the oils. Attach the electrode to the ECG cable before placement. And the reason why is if you put the stickies on, then you have to push real hard on the patient for it to connect. That sometimes can get uncomfortable, especially for like your brittle little bitty older ladies. It's uncomfortable. There are ways you can do it without causing pain, but the correct answer is apply the pads prior to placement. And then you want to confirm that the appropriate electrodes are attached and the cable is placed in the correct rotation on the patient's limbs. And here's you a picture. So I'm going to tell you an idea on how to remember this. So if you'll see on this picture right here, right there, white on right, smoke over fire, green is extra. So I'm telling you, I do this every time I go to put it on somebody. I'm like, white on right, smoke over fire. Because these 3 are your main ones. And you know you always heat up with the green one left over and goes there. At the same time as you can put them on the wrist and the feet. It doesn't have to be on shoulders and abdomen. It just depends on what your agency prefers. but at the same time, that's where you are. Now, let's move over to the next one. So figure 1711 is showing you a 12 lead. You have to have all 4 leads already in place, and then you apply lead V1, 2, 3, 4, 5, and 6. Now, let's do some math. That's only 10. I know, trust me, that there's only 10. I got that. But they call it a 12 lead. So guess what we're going to call it? A 12 lead. All right. So this one, V1 and V2 go dead center of the chest on norm. And I'm sorry to say this. Y'all can laugh. I know it's going to happen. But lead 1 and 2 go mid sternum on normal nipple placement. All right. You do it right across from the nipples, all the way across. The 3, 4, and 5, they basically want to cup the left breast. You don't have to do it so close to this. That's right there on the 5 is where the nipple is for this male. You can go lower than that for a female, but at the same time as you need to raise the breast, use the back side of your hand when you raise them. Let the patient know what you're doing. That's very important to let them know. And then at the same time is you need to undo or loosen their bra when you do it to a female. And then when you have these, I always like to tell the patient, do me a favor, close your eyes, relax, and be as still as you can until I speak to you again. I'm gonna count to 3. I'm gonna push this button. And then when I count to 3, I want you to close your eyes, slow deep breaths, relax. And then I push the button. So it takes a couple of seconds to run this 12 lead, but that is the correct placement of the 4 lead and the 12 lead. Don't know why they call it 12. I mean, I really do, but that's why. All right. So once the electrodes are in place, you switch. The monitor is going to be on. Most of the time, as soon, I can tell you for the LifePak 15s, I don't know what you will be using. As soon as they recognize that there is a cardiac rhythm, it automatically prints you a sheet. It'll print you a 4 lead sheet. You have to push the 12 lead button, enter their age, and if they're male or female, and you have to click it, enter again on their little dial button, and it runs a 12 lead. It'll print it off in 6-second strips, and you have to read it, all 6 strips. And at the same time as it will tell you what the projected rhythm is, but you need to verify that. I don't like when paramedics look at that and be like, oh, it's saying it's a first degree heart block. Well, first off, there is no heart block on here. But what the monitor is doing is looking at it in a longer than 6-second strip. So that's why it tells you that. So at the same time as my standing protocol for my company is we run them every 10 minutes. If you come to me with a chest pain, I do a left-sided normal 12 lead every 10 minutes, unless there is a change of status. Then I would run it instantly. It gets a lot of paper when all this starts happening. So you could kill a lot of trees doing that. All right. So heart surgeries. Over the past 40 years, hundreds of thousands of open heart operations have been performed. We have bypass coronary arteries in the heart, and a coronary artery bypass graft, a blood vessel from the chest or leg is sewn directly from the aorta to the coronary artery beyond the point of obstruction. Most of the time it comes from the inner of the thigh, not the chest. Let's see, a tiny balloon is attached to the end of a long, thin tube and introduced into the large artery to get rid of this transischemia. A tube is threaded to the narrow coronary artery and inflated. The balloon is then deflated and the tube of the balloon are removed. Sometimes stents are placed inside the artery. Sometimes they can't do that, and that's where you get the bypass from. Patients who have had bypass procedures may have or may not have a long scar on the chest. That is a big telltale sign. You see that little scar around the top part of the chest? It guarantees you when you go to do CPR on them, you're going to break their sternum. You want to treat chest pain patients who have had any of these procedures in the same exact way that you're going to do it on any other person. So pacemakers will do their best to get to a regular rate and rhythm. But that being said is you need to make sure you find that pacemaker. A lot of your pacemakers are on the left chest area, and they do that because of placing a AED pad. You don't ever want to place an AED pad over on the top of one of these. Some pacemakers and defibrillators are going to be in the same areas. So that being the case, I'll tell you a little story. First time I run a patient, he was like, "Hey, I have a pacemaker," and I was like, "Okay, all right, cool." Started working on him, and then he started jerking. He's like, "Oh God, oh God, oh God!" And I was like, "What the hell is wrong with you?" Guess what? He had a defibrillator instead of a pacemaker. As Rose stated there, you can have them in their abdomen too. It just depends what facility and what the surgeon prefers. There's really no rhyme or reason versus the chest versus, and sometimes they're put in certain places because of like seat belts versus, lap belts. They try to break it down and tell you why it's done here versus there. I've seen the same facility and the same doctor put them in two different places. So when I say it does depend. It just whatever mood that they're in. Let's see here. They're inserted when the electrical system of the heart is damaged. It needs a jumper. Basically, they need jumper cables to be applied. These battery-powered devices are delivering electrical impulse through wires that are directly connected to the myocardium. Basically, like I said, it's a boost. The generating unit typically resembles a silver dollar and is usually placed under heavy muscle or fold in the skin in the upper left portion of the chest. I know that every 10 years, they will stop, look at them, check the batteries, because a lot of these now they can go up to them and read them with a certain type of machine and tell you what battery's there. They can get all the important information off of them. But I know in time past, it used to be to where every 10 years they had to be replaced. It's not like that anymore, or so much, but at the same time, it is pretty, it's nice that they can do that without having to go back in there and have surgery. There's a picture of a pacemaker. The technology is very reliable, like it shows. When they do not function properly, the pacemaker can cause a patient to experience a syncope, dizziness, or weakness due to the excessive low heart rate, because over time they're like, it's just been feeling so good. All of a sudden, I just feel like crap. So, and the pulse will ordinarily be less than about 60 beats a minute, because you remember, the original SA node is not firing, so the secondary electrical pattern is firing, and that's from the myocardial. So that's why it's a lot lower. When an AED is used, the patches should not be placed directly, like I already told y'all that. And if the patient has a malfunctioning pacemaker, it should be taken to the emergency department, because those are the ones who's going to be able to fix that. And you need to go to theirs. If they're not from the area, you need to take them to another cardiac related facility. But if you're there and it's not the closest facility, they need to go to where they had it put in. Now, I'm not going to transport the patient, 8 hours to their home in, Memphis, or not Memphis, that's 3 hours for me. But y'all know what I'm saying. I want to go to the closest facility that can handle that if it's not their particular one. Oh, let's see here. What is this one? So an automatic implanted cardiac defibrillators are sometimes used by patients who have survived cardiac arrest due to ventricular fibrillation. These devices continuously monitor the heart rhythm and deliver shocks as needed. It will not shock you at all. Treat these patients like they are all other patients having an MI, including CPR, transporting to the facility, giving them an AED, chest, sorry, my daughter just dumped bowls all over. And the electrical from the automatic implanted device is so low that they have no effect on rescuers. Again, I have seen them jerk like that from continuous shocks, but it's not something that's going to affect you. It will show up on your cardiac monitor if you're helping your paramedic, and you will notice that as you go in. And ask, I always like to say, ask your medic to teach you some. That is very beneficial for you to learn. So LVADs are being more and more popular in the areas. We used to not have LVADs a lot. LVADs, I like to tell you the best thing you can do about an LVAD is if you find somebody that has one, they don't go far from their home because they have to stay close to an electrical device. Now they can and they will have battery packs too, but they do plug them in pretty regular. But an LVAD it's basically a pump of the electrical ventricle where the patients have suffered heart failure, but they need a temporary boost to an MI. So the most common ones have an internal pump and an external battery pack. It literally it's bulky. When you notice, be like, what is all that? What it is the pump are always continuous, and some patients will not have any palpable pulse. So when you go to check their pulse, they don't have a pulse at all, like they're walking mummies. But this LVAD is what's beating. It gives them all their functionalities. It makes their heart circulates and everything. If the device malfunctions, is the only time that you should mess with it. Other than that, never mess with their LVAD unit. Always call med control if you have any questions. And then you always want to transport all LVAD supplies and batteries with the patient. If for some odd reason you're picking up a patient in a very rural area, they have a charging station, they have all that crap with you, I promise you're going to be like, I'll just bring it with you. Because it's going to make you nervous. I've transported one LVAD in 20 years, and the dude was super knowledgeable, so knowledgeable about it. The only weird thing is that his hands were so cold because he didn't have a pulse. It was weird. Cardiac arrest, we know this is it's indicated in the field by the absence of a cardiac pulse. Cardiac arrest was almost always terminal until the event of this CPR and ED in the 60s. With good CPR on a cardiac monitor, you can see the rate and rhythm change. You can also see a good change of the patient's respiratory system. When you're bagging them and you give good ventilations, you will notice that on your monitor also. Here's AEDs. I know everyone y'all have had CPR, so you at least know what an AED is. If you've never used one, they tell you these are very, very, very easy. Here is also another type of AED. Every company and their brother has something that is similar, but is different at the same time. So they all functionality parts are the same. You just listen, you pull it out, look at the directions. See right here, this one goes on the left, the upper right chest. This one goes on the lower left side, and you plug it in and listen to whatever the monitor tells you to do. If it tells you to stop CPR, make sure you do that. Joshua says we had one in our area. Yeah, and the LVADs are becoming more and more common, but at the same time is they don't really ever call 911 unless there's an issue with the LVAD. And most of the time, the people that have them do a education with the local ambulance and fire service, just in case. They're very open and they like to teach, because at the same time, it's like, this is my heart that is right here in this pump. I need to make sure you as a provider understand what it is. Yeah, and this is the thing too, Josh, is Joshua, sorry, that when those LVADs mess up, they mess up bad. And I can tell you, I don't want them. If it means flying them, all right, cool. We'll fly him. We'll get him out of there in a heartbeat. I ain't worried about that bill. That's on them. Let's get them out of here. Oh, let's see here. I'm gonna pause that right here. We're gonna take 10 minutes and then we'll come back and finish this up. We ain't got much more to go. But I need to go make a quick phone call. And let's see, what time is this? It is 7:48. Well, I'll tell you what, let's see you straight up 8 o'clock. How about that? I'll see y'all in 12 minutes. Any questions so far? All right, see y'all in 12 minutes.
Run was wearing this on my bag. I'm sorry.
All right, folks. Sorry about the little break. I had to stop and make that quick phone call. All right, so over here, so no other really other considerations about AED. The biggest thing you want to do is make sure that they're not in water. You want them to be clean. You want them to be dry. Make sure that they're, like I said, no puddles of water or anything like that, because it's going to turn around and affect you too if they're left in water. As you can see, asystole indicates no electrical activity. It will not shock asystole, so you don't have to worry about that. Let's just say pulse electricity, electrical activity usually refers to a state of cardiac arrest that exists despite an organized electrical complex. Early defib is always the best thing that we can do. Few patients who experience sudden cardiac arrest outside of a hospital survive unless a rapid sequence of events that take place. Y'all remember our chain of survival? Bam, look at there. It's on the chain of survival, it's right there. So, and then y'all remember this wonderful picture. Here's our chain of survival. That is where we need to continue this. And I like to say right in here is education. Education helps with the CPR process. It helps with the defib process. Obviously, you guys are right here in the chain because this is the basic and advanced EMS. We want you to come into here, into the ALS post-arrest care. We hopefully one day can also see y'all coming around as, you know, basics to advanced to paramedics. They didn't have advanced when I went through. So I went straight from basic to an advanced, to a paramedic. So, but you can do that too. You don't have to go to all 3 levels, but just to let y'all know. So we know that CPR does prolong the life, the period between defib, but at the same time, it helps. They need to go hand in hand if possible. Defib works best if it takes place within 2 minutes of going into cardiac arrest. Again, that's ideal. But I mean, if you have to go get the AD or you're waiting 2 minutes for somebody to bring it back to you, again, at least you're doing 2 minutes of CPR. So you're trying to help your patient there. You're not just standing around twiddling your thumbs. I like to remind people and tell them that not just because you may be emotionally attached or something isn't deal. It may not be your day to do CPR. Maybe you're affected by because it's a child. But it's not. It's okay. You can step back and say, I can't do that right now. We push the mental state of each other very big. It's okay to where once there's other lay people, other certified responders around, that you can say, hey, I need you to take my place. I'm not handling this well. I've let my pride get in the way in the past, and it's hurt me over the years. I've had issues when I was in Afghanistan and Iraq that affects me still to this day. There's certain things that I can't deal with. There's certain sounds, smells, and just surroundings that I don't function well with. So it really wasn't pushed for mental health as big as it is now. I'm really big into taking care of yourself. There's times that I'll tell y'all, starting this weekend, it's my last weekend before I'm home. So I will zone out completely. I kind of do my last little bit with the family to take care of mental health before I go back to work. I try to make sure that my mental health and state is taken way care of a lot better than what it was in the past. But we just didn't really push that. I recommend don't work so much in EMS that you rely on the overtime, but work enough to where you're happy with yourself. So just remember, it's okay to say, hey, time out. I need to step away. So automated external defibrillation, ALS, we know that they're going to come in. They're going to continue everything that you kept on. We want to make sure, just because I'm a paramedic doesn't mean that I'm going to come in and take over and tell you what you need to do versus not to do. That's not how it is. That's how I will not do that. even if I work with a really good partner and my partner goes in and initiates patient care, I will not step between them. I sit back, I listen, I reserve, I write notes. Just because I'm a paramedic doesn't mean that, oh, I'm in charge, I got to do it all. No, that's not, I don't function that way. I just don't think that's a good thing. And I try to recommend that not all paramedics do that because it hinders things. It hurts you as a basic to continue your education. I'm integrating AED and CPR. You went over that through CPR, so I'm not going to harp on that. AED maintenance, it depends on what kind you have. Let's say if you're like a Life Pack 12, Life Pack 15, if y'all notice, I talk about the Life Pack 12 and 15 because that's really all I know. Those are the ones that I've worked with in my areas. All the services I've ever worked for have those. So that's kind of my, I don't want to say that's my area of expertise, but I know those machines very well. But the AED maintenance, basically, you want to make sure the battery's good, the pads are within date. A lot of these have disposable batteries now that you just change out the battery pack. Some battery packs for 2 years, and then you have to discard it. We like currently on the rig, we have AEDs on 3 of our floor, 3 of our, well, out of the 7 stories that our building, our rig is, we have 3 of them that are on the facility. And we all have extra pads and extra batteries that are with all of these. And that's not counting my monitor that's in my clinic. So, and I'm responsible for making sure that they're all good and have these things. The big life packs automatically do a daily check. The little ones don't. So it's something you don't really have to worry about there. So medical direction, they teach you that when you go through your new orientation on what you can and can't do and your written protocols for AEDs. And continuing ed is some agencies may require you to show your skill competency. And if there's any questions, they just try to teach you and educate you on the fly. Preparation, you just want to make sure that your AED is good to use, that you know how to use it, you're familiar with it. Do not defib patients in pooling of water. Electrical will go through the pool of water, and you will know it too because you have been shot. You can defib a soaking wet patient, but dry the patient's chest first because, again, you got to get these pads to stick. They need to make sure they adhere. Do not defib the patient if they're touching metal because electricity likes to follow through metal and it'll go down the path and may hit another bystander. If we talked about this in the medical part, if a patient has a transdermal patch on, remove that, specifically if it's a nitro patch, and wipe that area super clean the best that you can. If you don't, they can get a massive dose of that at one time. But again, be careful. Make sure you remove those, clean them. You want to try the ALS as fast as you can. Sometimes you can't. It just depends. You may have to work this call until ALS gets there, and it may be another 10 or 15 minutes. It depends on where you are. Our central Mississippi, every ambulance has to have a basic, advanced, or paramedic on it. That is a requirement by Central Mississippi protocols. Another larger company that's right next to the county that I'm in, they do have sprint trucks, even though the ambulances run a paramedic and a basic. They also have sprint paramedics that sprint to help out. And they're also RSI certified, which is rapid sequence intubation. So they RSI if need be, and they can transport to the hospital with that. There's a flow chart. Most of your protocols will also be into this form. This is a flow chart if you've never seen one. A lot of them will be color coded. This is the flow chart for use of a AED. That's an algorithm flow chart, kind of the same thing. Went over that in CPR. I'm not gonna harp on y'all. I'm not harping on that. So some agencies do not allow you to do CPR AED while the vehicle is moving, as in a transportation ambulance. That is their protocols, their rules. I can't give you any justification to whom, what, when, where, or why that is, but that is their company's rules. So if your company says, hey, if their patient goes in cardiac arrest, you must stop the vehicle on the side of the road, notify the dispatch, and blah, 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 blah. They teach you that. They go through that process. If you need ALS, make sure you call for them early. Let them know that they are responding to a cardiac arrest. Even though that they're coming, don't withhold that defib. You're going to have at minimum an AED on board. Don't withhold that from them. Make sure that you deliver that as soon as you can. Big ding, ding, ding right here. Follow your local protocols for coordination. I can't teach you that. All I can do is just tell you, this is what you follow your local protocols. If you're able to get a copy of your local protocols in your state, your area, or your town, that will help you learn early and the better that you can. All right, so management of spontaneous circulation. That word gets me. All right, so monitor for respirations. If at all they start breathing, you want to provide a bag valve mask at 10 breaths a minute. Then you want to maintain an O2 saturation between 95 and 99. Check for pulses. I like to say at this point, you need to check at least in 2 different places of 2 different arteries. That helps confirm. If the patient can follow simple commands, give them and explain to them in clarity what's happened, what's going on, and what is going to take place. If an ALS is not on scene or en route, immediately begin transporting patient to the closest facility. Again, following your local protocols. They may tell you you have to wait for a ALS to transport if they do spontaneously can start. But the hardest thing is guys, just following your local protocols. That is the biggest part I need y'all to understand throughout this is protocols is the most important part that you can do for these things. Let me make a note to myself real quick. All right, so guys, listen, that's the end of the night. That is all of the slides I can give y'all. I can't give you any more knowledge that I have. I could dive off deep into it, but in the chat box, there is your code. Your code for tonight is 789123. That will be your code for tonight. Obviously, since y'all are aware that Reginald has already taken the test, the test should be open. I have not changed some dates all of a sudden. See, I called him out. He didn't really pay attention to that. Sorry, Joseph, I actually sent that to you instead of to everybody. So your code for tonight is down in the chat box now. Please, please, please let me know if y'all need any assistance. Again, this is a very big chapter. There could be a lot of questions on your test that relate to several different things. If you have questions, problems, concerns, please reach out to me. I'll be glad to help you folks out as much as I can, and I'll give you the best that I could. Does anybody have any questions, concerns? It is nicely thundering and raining its butt off here at my house. All right, folks, listen, if that's all nobody's got any questions or concerns, good luck to y'all on your test, and I will see y'all Tuesday. Please don't forget, Tuesday is a travel day for me, so it's going to be a little busy. I will, if for any reason we have to start a little bit later, I will let y'all know through Discord. But on that note, good night, and I hope everybody does well on their test. See y'all Tuesday.